Picture this. You're standing in the exam room, or maybe you're picking up a chart in the emergency department,
Right.
and you are evaluating a patient who has just presented with an agonizing, completely debilitating acute gout flare.
We all know that exact presentation.
Yeah, I mean, you know the one. The first metatarsophalangeal joint is red, swollen, and just so exquisitely tender that even a bed sheet lightly brushing against it sends the patient's heart rate through the roof.
It's pure misery. They are looking to you for immediate relief.
Exactly. But then you look down and there is a massive flashing warning sign in their chart.
Yeah.
This patient has an estimated glomerular filtration rate, or eGFR, of 42.
Ah, right. So they have moderate kidney impairment.
Right there, you are thrust into one of the most stressful balancing acts a clinician can face. I mean, you want to relieve those agonizing symptoms aggressively, but the go-to medication for this, colchicine, carries severe risks of toxicity if it's not dosed with absolute precision in this specific population.
It is a phenomenal clinical dilemma, and it plays out in clinics, urgent cares, and hospitals every single day.
Yeah, it's incredibly common.
And we are not just talking about treating a painful joint in a vacuum here. We are talking about navigating a very narrow therapeutic index.
The stakes are high.
Incredibly high, because getting this wrong does not just mean the patient stays in pain. It means potentially inducing severe systemic and sometimes life-threatening harm through medication toxicity. This requires moving beyond standard protocols and applying a really precise, physiologically grounded approach to pharmacotherapy.
Okay, let's unpack this, because to understand the right way to handle this patient, we have to look at what most clinicians instinctively want to do.
Which is completely understandable.
Right. When faced with a patient in absolute agony, the overwhelming urge is to reach for the standard colchicine dosing. You just want to give that 1.2 milligrams followed by 0.6 milligrams an hour later.
It's pure muscle memory. But that compassion actually becomes the danger here. The urgency of pain control drives the instinct to use familiar aggressive dosing patterns because in a patient with normal renal function, it reliably blunts that inflammatory cascade.
You want to hit the neutrophil response hard and fast.
Yes, but that default instinct absolutely shatters when you introduce a compromised eGFR into the equation.
So I get that clearance drops. But what does that actually look like for the patient physiologically? Are we talking about a slow buildup over several days, or is this an immediate crash into toxicity?
It's really about understanding the area under the curve, or the AUC, for this specific drug. So colchicine is primarily metabolized by the liver, but the kidneys are responsible for clearing about 10 to 20% of the unchanged drug.
Okay.
And even more of its metabolites. So when a patient has an eGFR sitting between 30 and 59, which defines that moderate impairment window we're talking about, the clearance half-life of colchicine extends significantly.
It just hangs around.
Right. If you administer a standard dose, the drug does not clear before the next dose is given. You get an exponential accumulation.
It reminds me of, it's like pouring a gallon of water into a clogged funnel.
That is a perfect analogy.
Right. You pour it in too fast, it backs up
Yeah.
and causes a massive mess.
Exactly. And because colchicine works by binding to tubulin and halting microtubule polymerization, it doesn't just stop neutrophil chemotaxis in the joint. It halts cell division and cellular transport everywhere.
Everywhere in the body.
Yeah.
Which is why the toxicity hits specific organ systems first.
Right.
It targets tissues with rapid cell turnover.
That is the crucial clinical insight. The mucosal cells of the gastrointestinal tract have incredibly high turnover.
So it hits the gut hard.
Very hard. When colchicine accumulates, it halts mitosis in the gut, leading to severe sloughing, which manifests as profound diarrhea and vomiting. Furthermore, microtubules are essential for axonal transport and muscle cell integrity. Toxic accumulation disrupts this, leading to neuromyopathy and potentially rhabdomyolysis. You are essentially poisoning the patient's foundational cellular infrastructure.
So the standard dose is completely off the table. Let's get into the exact numbers of the intervention. When you were standing there making the prescribing decision for this moderately impaired patient, what is the modified game plan?
The clinical framework for a patient with an eGFR between 30 and 59 is to initiate therapy at a drastically reduced dose. We are looking at a starting dose of 0.3 to 0.6 milligrams.
Okay, 0.3 to 0.6.
Yes, and depending on your clinical assessment of the patient's overall frailty and exact eGFR, that is given either once daily or every other day.
But wait, if I give them a tiny 0.3 milligram dose every other day, Aren't they just going to end up bouncing right back to the ER tomorrow because I undertreated their agonizing pain?
What's fascinating here is the ceiling effect of colchicine's anti-inflammatory properties compared to its linear toxicity curve.
A ceiling effect.
Yes. Studies suggest that maximal intracellular concentration in neutrophils, which is what actually stops the gout flare, is achieved at much lower systemic doses than we historically believed.
Oh, that's really interesting.
Pushing the dose higher in a renally impaired patient does not recruit more anti-inflammatory power. It only drastically increases the systemic toxicity. By constraining the dose to zero point 0.3 to zero point 0.6 milligrams, you are hitting that therapeutic ceiling for neutrophil inhibition while staying safely below the threshold for catastrophic cellular toxicity.
And there's a hard stop on the total cumulative dose for that flare, correct? We aren't just letting them take this reduced dose indefinitely until the pain stops.
Absolutely not. You must not exceed a maximum total cumulative dose of roughly 3 milligrams during the entire acute flare.
3 milligrams total.
That total is just as critical as the daily starting dose. Once you hit that 3 milligram ceiling, if the patient is still experiencing symptoms, colchicine is no longer your tool. You have to pivot to alternative modalities.
Here's where it gets really interesting, because medicine is never just a math problem.
It never is.
We have this core decision framework, but what happens when the patient has other complicating variables? What are the physiological factors that force a clinician to abandon even this modified dosing strategy?
Vigilant chart review is non-negotiable here. There are two critical patient factors that completely alter your trajectory. The first is dynamic renal function.
Right, because EGFR isn't static.
Exactly. We defined moderate impairment as an EGFR of 30 to 59. But if that patient is dehydrated from the gout flare, or maybe they've been taking NSAIDs at home, their EGFR might be actively dropping.
That makes sense.
If they cross that threshold into severe impairment, an EGFR below third, the 0.3 to 0.6 milligram rule goes completely out the window. The toxicity risk at that level of impairment is simply too extreme. You typically avoid colchicine entirely and look towards systemic or intra-articular corticosteroids, assuming there are no contraindications there.
So dynamic kidney function is factor one. You have to know what their kidneys are doing today, not just what their baseline was 6 months ago. What is the second major variable?
Metabolic interference, specifically involving the cytochrome P450-3A4 pathway and P-glycoprotein efflux pumps.
Oh, CYP3A4, the classic interaction pathway.
It is. Colchicine relies heavily on CYP3A4 for hepatic metabolism, and P-glycoprotein acts as a bouncer in the gut and biliary system, actively pumping the drug back out to prevent excessive absorption. If a patient is taking a medication that inhibits either of these pathways, you have a massive pharmacological crisis on your hands.
Give me some concrete examples. What are the common interacting drugs that a clinician might breeze past on a rapid medication reconciliation?
Macrolide antibiotics are the classic offenders.
Like clarithromycin.
Exactly. Say your gout patient recently went to an urgent care for a sinus infection and was put on clarithromycin. Clarithromycin is a potent CYP3A4 inhibitor. Other common ones include calcium channel blockers like diltiazem or verapamil used for hypertension, or antifungals like ketoconazole. Cyclosporine is also a major P-glycoprotein inhibitor.
Let's ground this in reality. What does it actually look like when those pathways are blocked in a moderately renally impaired patient?
I can give you a textbook scenario that critical care physicians see far too often. You have a 65-year-old male with chronic kidney disease, stage 3A. He is taking atorvastatin for his cholesterol. He develops an acute gout flare.
Okay.
His primary care physician appropriately prescribes the renally adjusted colchicine dose, but 3 days prior, a different provider prescribed clarithromycin for a presumed atypical pneumonia.
Oh, no.
The clarithromycin halts the CYP3A4 metabolism of both the colchicine and the statin. Furthermore, the patient's compromised kidneys cannot clear the excess. Within 48 hours, the patient presents to the emergency department with profound proximal muscle weakness, dark urine, and a creatine kinase level of 45,000.
45,000. That's catastrophic.
He is in fulminant rhabdomyolysis and multi-organ failure. It happens incredibly fast.
That is terrifying.
Yeah.
Because you have two elimination systems failing simultaneously, the impaired kidneys and the blocked hepatic metabolic pathways. You're essentially trapping the drug inside the patient.
You are removing all of the body's natural defense mechanisms against drug accumulation. If those interacting drugs are on the chart, you must lower the colchicine dose even further, sometimes by 50 to 75%, or, much more safely, choose a different therapeutic agent altogether.
Let's talk about the clinical timeline for the patient who does fit the criteria. Moderate impairment, no CYP3A4 inhibitors, no P-glycoprotein inhibitors. You start them on the zero point 0.6 milligrams. How long are we waiting before we decide if this intervention is actually working?
The critical window for evaluation is 24 to 36 hours. You initiate therapy and you monitor. If the patient's severe pain and inflammation are still poorly controlled after that initial 24 to 36-hour period, you have to reassess your strategy.
So no waiting around for days.
No. Cautious dose escalation is sometimes considered by specialists, but more often, this is the time to look at adjunctive therapies. Maybe adding a low-dose corticosteroid or considering an IL-1 inhibitor like anakinra if the situation is refractory and resources allow.
And during that 24 to 36-hour window, what are the immediate clinical red flags? What are the physiological warning sirens that tell you to pull the plug on the colchicine instantly?
The earliest indicators are almost always gastrointestinal. And we are not just talking about mild nausea. We are looking for severe, sudden onset vomiting or profuse diarrhea.
So you don't just brush that off.
Never. In a patient with renal impairment on colchicine, you must treat those GI symptoms as heralds of systemic toxicity, not just a mild drug intolerance. The second major red flag is any neurological or muscular symptom. If the patient reports new onset weakness, unexplained muscle aches, or numbness and tingling, that points directly to neuromyopathy.
You cannot just prescribe an antiemetic and tell the patient to push through the nausea.
Doing so would be clinical negligence. If those symptoms appear, it requires immediate cessation of the drug and an immediate lab draw to check renal function, liver enzymes, and a creatine kinase level to assess for muscle breakdown.
So we really have this tightrope walk of dosing. But I imagine even with the best intentions, things go sideways in busy clinical environments. Let's dig into the most common ways this gets mishandled. What are the absolute do-nots when managing this specific patient population?
The most prevalent error is defaulting to standard dosing without adjustment, which we have covered extensively. But the inverse error is also a massive pitfall. Clinicians often assume that because they prescribed a reduced dose, the patient is automatically safe, and they fail to monitor for undertreatment.
How do you balance that? If undertreating an agonizing flare is a major concern too, how do you ensure efficacy while maintaining that safety profile?
It requires active clinical follow-up. You do not just send a prescription to the pharmacy and tell them to follow up in a month. In a renally impaired patient, you need a touch point, a phone call, a portal message, or a quick recheck within 48 hours to confirm the joint inflammation is actually subsiding. A reduced dose is a starting point, not a guarantee of efficacy.
What about extrapolating these guidelines to other groups? Say a patient comes in and they are on hemodialysis. Do these rules apply?
Absolutely not, and that is another critical pitfall. You cannot treat a severe renal patient or an end-stage renal disease patient on dialysis with moderate renal impairment rules.
Because the clearance is just zero.
Right. Dialysis does not effectively clear colchicine due to its large volume of distribution and high protein binding. Giving even reduced doses of colchicine to a dialysis patient is incredibly dangerous and is generally contraindicated for acute flares.
I often see clinicians relying heavily on automated pharmacokinetic models in their electronic medical records. The computer flags a dose adjustment based on the eGFR. The clinician clicks accept, and they move on. Is that sufficient?
Relying strictly on pharmacokinetic models is a dangerous trap. Those algorithms calculate estimated clearance based on formulas like Cockcroft-Gault, but they do not account for the patient's dynamic clinical state. Is the patient volume depleted? Do they have acute kidney injury layered on top of their chronic kidney disease? The clinical reality of the patient sitting in front of you always supersedes the theoretical model generated by the EMR.
Another thing that gets confusing is the different indications for colchicine. You have the acute gout flare, which we are discussing, but you also have chronic gout prophylaxis when initiating urate-lowering therapies like allopurinol.
Mixing those up in a renally impaired patient leads to terrible outcomes. Acute flare dosing and chronic prevention dosing are fundamentally different strategies. Prophylactic dosing is significantly lower and is sustained over months. If a clinician mistakenly uses acute flare dosing parameters for chronic prevention in a patient with an eGFR of 40, they will inevitably induce cumulative toxicity over a matter of weeks.
And we touched on this earlier, but I want to reiterate the drug interactions. Missing a CYP3A4 inhibitor on a medication review is not just a minor oversight.
It is a catastrophic pharmacological error. As we discussed with the clarithromycin example, ignoring those interactions directly causes the colchicine AUC to spike exponentially.
What happens when the patient hits that 3 milligram cumulative dose ceiling over the course of the flare, but they are still complaining of moderate joint pain? There is a temptation to just prescribe a few more pills to get them over the finish line.
Extending treatment beyond symptom relief or pushing past that recommended 3 milligram maximum offers zero added clinical benefit while drastically steepening the toxicity curve. If you hit the ceiling, you must stop. You transition to topical ice, joint rest, and alternative systemic therapies.
I also read arguments that clinicians should sometimes risk higher doses to keep patients out of the hospital, suggesting that undertreating leads to admissions for intractable pain.
Letting broad hospital admission metrics drive your specific dosing decisions in this vulnerable population is a flawed approach. The evidence correlating these specific colchicine dosing adjustments to overall hospitalization rates in moderately impaired patients is incredibly weak. Your decision must be driven by the physiological safety parameters of the individual patient, not a generalized desire to keep admission numbers down.
So what does this all mean? We have laid out a precise physiological framework, the metabolic exceptions, and a strict list of clinical pitfalls. But any clinician listening knows that the bedrock of medical evidence is rarely perfectly black and white. There are always gray areas in the literature.
If we connect this to the bigger picture, we have to acknowledge the conditional nature of the data guiding us. Physiologically, pharmacokinetically, and observationally, we know that reduced dosing balances symptom relief and safety. But the reality is that robust, randomized, direct head-to-head clinical trials comparing standard versus reduced colchicine dosing specifically in the moderately renally impaired population are virtually non-existent.
So we are essentially operating on expert consensus, pharmacokinetic principles, and retrospective safety data.
Correct. Because of that lack of direct level 1 evidence, the safest, most defensible path forward is the start low, go slow methodology we have outlined. You initiate the reduced dose. You monitor the patient intensely for the first 1 to 2 days, looking simultaneously for the resolution of the joint erythema and the onset of any gastrointestinal or muscular red flags.
And then adjust based on that.
Yes. You evaluate that dynamic response, and you pivot rapidly if the clinical picture shifts. It is the most patient-centric, physiologically sound approach available to us.
It really brings it all back to the concept of vigilant, active clinical management. You're not just firing off a prescription and walking away. You are initiating a highly monitored trial of a narrow therapeutic index drug. So to distill this incredibly complex physiological discussion into a single memorable clinical rule.
Go for it.
For adults presenting with an acute gout flare who also have moderate kidney impairment, meaning an eGFR between 30 and 59, your immediate evidence-based move is to start colchicine at a reduced dose, specifically 0.3 to 0.6 milligrams daily or every other day, absolutely not exceeding a maximum cumulative total of 3 milligrams for the duration of the flare. You must monitor them dynamically over the first 24 to 36 hours for both efficacy and cellular toxicity, and you must never apply these specific rules to patients with severe kidney impairment, those on dialysis, or those taking CYP3A4 or P-glycoprotein inhibitors.
That is the essential operational summary for immediate practice, but I want to leave clinicians with a broader, more provocative physiological concept to consider.
Please do.
We have spent this entire discussion dissecting the incredible, dangerous tightrope walk of clearing a toxic, microtubule-inhibiting drug through compromised kidneys. It requires constant vigilance, complex dose adjustments, and a deep, abiding fear of multi-organ toxicity. Given all of these inherent dangers and narrow margins for error, will the future of acute gout management for renal patients eventually shift entirely away from trying to endlessly adjust these kidney-dependent drugs?
It would change everything.
As our understanding of immunology advances, will the standard of care inevitably evolve to focus exclusively on targeting entirely new inflammatory pathways, perhaps directly inhibiting the NLRP3 inflammasome, or utilizing targeted interleukin-1 receptor antagonists that bypass renal metabolism and hepatic interactions altogether, ultimately rendering this specific, dangerous balancing act obsolete?
It is a profound question regarding the future of targeted immunomodulation, and one that highlights how fast the landscape of pharmacotherapy is always evolving. Thank you for joining us for this clinical breakdown. We hope this deepens your physiological understanding and empowers your decision-making the next time you face this exact presentation in the clinic or the ED. Take care and keep practicing safely.
Goodbye, and thank you for listening.